She underwent an EGD, which shows a dilated esophagus with moderate resistance encountered on passing to the gastroscope through the LES and normal esophageal mucosa. She underwent a high-resolution manometry, again in July 2025, which shows absent peristalsis and elevated IRP of 23.3, consistent with Achalasia type 1.
So I'm using the latest scope from Fuji. This is the EG840TP, 7.9 millimeter diameter and a 3.2 millimeter channel. So it's a slim scope with a therapeutic channel. And you see very high-end imaging and extreme flexibility. So the way POEM has changed is that long myotomy is the issue with long-term symptom recurrence, because these patients are gonna have a high chance of developing blown out myotomy. Accurate interpretation of where the lower esophageal sphincter is helps us do a very short myotomy, because if it's too short, it's gonna be ineffective. If it's too long, then the patients are gonna develop reflux and blown out myotomy. There, the goal is to perform 4 centimeter myotomy on the esophageal side and a maximum of 2 centimeter on gastric side. We just did endoflip and we will do it live afterwards. The sensibility index was between 0.6 and 0.8.
Settings on electric cautery and the importance for these types of procedures. What settings are you using for that?
Yeah, so, and you see how just a short incision and you slip through very quickly. So we're using the Vio 3 Urbic. We're using Endocut Q 311 for the incision. And then I'm using spray coag here, 40 watts, for tunneling. Tunneling on the surface of the muscle. The goal is to protect the mucosa. That's our protective layer. So we want to cut exactly here at the interface between the submucosa and the muscle. And you see here, I'm injecting through the scope. This is something we described a long time ago, and this is how we do all our POEMs. You just inject through the scope, and it can stay in the submucosa well. It can expand the submucosa, some injection in the submucosa to expand it a little further. And, you know, sometimes we do a limited myotomy here at the LES to enable us to go in without lacerating the mucosa. But you see how tight this is. You just blunt injection like that. Okay, that's good. So we take advantage of the injection there. And then we use the cap to expand and separate the layers. We just started here a few centimeters above, and we have very accurate interpretation where the LES is. Look how narrow here. And we can peek into the gastric cardia and see about a 2 centimeter tunnel there. So again, very limited myotomy on both sides. And then I'm gonna do endoflip. And if I don't like the increase in DI, then I can cut more. If you are aggressive in the cut, there's no going back. So, so again, this move towards shorter myotomies is the way to go, in my opinion, these days. 30 diameter is going above 10. And the distensibility now is 4.5 or 4.6. I mean, there is no reason to have a more distensibility like that. As long as you know your landmarks, this is the way to go.